Today, why two FDA-approved cannabinoids are being tested as adjuncts to buprenorphine in opioid use disorder. A patient is on maximum dose buprenorphine for 3 months. Urine is still positive for fentanyl. They are anxious, can't sleep, and their pain is back. That scenario is the Fentanyl-Era norm, not the exception, and it is the clinical gap that a new Montefiore trial is designed to probe. Buprenorphine halves all-cause mortality in opioid use disorder when patients stay on it for at least 3 months. The problem is retention. Across the OUD treatment literature, only 40 to 60% of patients are still in treatment at 3 months. Among people who use fentanyl, nearly half return to opioid use within that window. So the medication works. The treatment course does not survive. What is driving that gap is not craving alone. It is a protracted withdrawal syndrome. Anxiety, pain, insomnia, and cravings can persist for weeks to months after starting buprenorphine, even on maximum doses, in people whose opioid receptors have been saturated by high-potency fentanyl. Standard adjuncts are short-term. Alpha-2 agonists like clonidine help some symptoms but can't be used long-term. There is a real pharmacologic gap to fill. The biologic case for cannabinoids is straightforward. In 2 randomized trials, dronabinol synthetic T.H.C. reduced acute opioid withdrawal symptoms and pain. In a separate randomized trial, cannabidiol C.B.D. reduced cue-induced craving and anxiety in heroin-abstinent adults. The combination is the strategic bet. T.H.C. for the withdrawal and pain, C.B.D. for the craving, and to buffer T.H.C.'s anxiety and cognitive effects. The DEMURE trial at Montefiore is testing exactly that. Dronabinol 20 mg a day plus Epidiolex 800 mg a day, titrated over 2 weeks, for 8 weeks, in 40 patients within 21 days of buprenorphine initiation against matched placebo. Primary outcome, 12-week retention. The eligibility list is the safety frame. In adults with OUD newly started on buprenorphine with active withdrawal symptoms or continued opioid use, and any past cannabis use at age 18 or older. Out, positive urine for cannabinoids, liver disease, pregnancy, unstable cardiac disease, psychotic disorder, history of seizures, severe alcohol or benzodiazepine use disorder, or any other contraindication to T.H.C. or C.B.D., the trial is not for active cannabis users. It is for past users who are now abstinent. That detail matters. The opening is real. Fentanyl changed the math for buprenorphine, the retention gap is the bottleneck, and the mechanistic case for a cannabinoid adjunct is grounded in 3 randomized trials. The clinical evidence is not. DEMURE is a 40-patient pilot, not yet recruiting, with primary completion in May 2028. The question this trial will answer is whether the mechanistic case survives contact with a real OUD population in the fentanyl era. Watch for it. In the meantime, the safety lessons from the cannabis and psychosis literature are the boundary. Vulnerable patients should not be on this strategy. Questions or episode ideas? Drop them below and subscribe for more psychopharmacology breakdowns. Educational purposes only, not a substitute for clinical judgment.